Afternoon, everyone, and welcome to this month's Lunch and Learn session for the London Centre for Work and Health. I'm Vaughan Parsons, the Centre Manager. I'm delighted to introduce Brendan Dempsey. Brendan is a research fellow based at University College London. Brendan will be presenting findings from a literature review piece of work that he's been involved in with regard to long COVID among NHS workers. Brendan recently completed his PhD at the University College Dublin in the School of Medicine, and his PhD project was focused on healthcare providers' experiences with liberalised abortion care in the Republic of Ireland. So quite different to what Brendan will be presenting today. So just encourage everyone to please put microphones on mute, and we'll take questions at the end of his presentation. So over to you, Brendan.
Perfect. Thank you, Vaughan, for that introduction. Yeah, a little bit different in terms of what I did my PhD in, but interesting nonetheless. Yeah, my name is Brendan Dempsey. I'm a research fellow in ARC, the NIHR, ARC North Towns based in UCL, and I work on the NHS Check project. And the work today is supported by the Cold Foundation. So yeah, for an overview of the talk, I'll start first by introducing long COVID, and then I'll move into the general body of research that has explored the symptoms and the prevalence, the risk factors associated with the condition. And then I'll introduce the narrative literature review that I conducted that explores the published literature around healthcare workers' experiences with long COVID. And then I'll end by considering some of the key areas requiring future work in this field. So, you know, just I suppose introduce, I'm sure there's no single person in the room that doesn't know about the COVID-19 pandemic or even in the world at this stage. But obviously, the emergence of the SARS-CoV-2 virus in late 2019 led to a pandemic. We're all familiar with that. And obviously, estimates suggest, and this is from our World in Data resource that is available online, that over 770 million diagnoses of COVID-19, the respiratory illness caused by the vaccine, have been confirmed to date across the world. So, although it's a large figure, potentially a huge underestimation, considering people that didn't get tested, people that were asymptomatic, and also lower income countries that didn't have as robust a testing service as potentially we did here in Europe or in the US. But clear that it was obviously a huge issue that affected the whole world. And common symptoms of the acute COVID-19 infection include, but obviously by no means limited to, cough, fever, and also fatigue. And it's important to note that while many people experience no symptoms, and some people only experience symptoms during that acute first 2-week phase of the COVID-19 infection, other people report experiencing symptoms for weeks, months, or even years after they first become infected. And really this has led to kind of the first descriptions of long COVID. And long COVID is the umbrella term that has been used to describe the complex medical condition whereby symptoms of COVID-19 persist or develop after that acute phase of the infection. And to date, a lot of different organisations and bodies have proposed different guidelines on how to define long COVID. But here in the UK, the National Institute for Health and Care Excellence have published their guidelines, and that the most widely were broadly used. And they differentiate between two kinds of long COVID. The first, less severe long version, is ongoing symptomatic COVID-19, which is symptoms that are between 4 to 12 weeks after the acute infection. And the latter is the more severe version of post-COVID-19 syndrome, or PCS. And this is where symptoms develop or continue to develop 12 weeks or more after the acute infection. And this second definition, PCS, aligns with other common definitions that are used in the research, the most, I suppose, prolific of which is the WHO definition of post-COVID-19 condition, which also specifies that symptoms should last for at least 12 weeks. Then kind of moving into the kind of growing body of literature, obviously since it was first described, there's been a huge interest in trying to explore and understand long COVID as best as possible. And unfortunately, in the 4 years since it was first described, there's no agreed upon cause as to why some people experience COVID. And to date, there's been a number of theories that have been suggested, some certainly more plausible than others, but none of them achieved any sort of scientific consensus or any kind of real support as to why some people experience long COVID. To look at symptoms then, systematic reviews and meta-analyses of that growing body of literature that has explored long COVID has found that as many as 60 symptoms are widely prevalent in relation to long COVID. And these include, but obviously are not limited to, fatigue, shortness of breath, loss of concentration, memory loss, muscle pains, joint pains, change to or loss of smell and or taste, cough, headaches or migraines, disordered sleep, chest pains, sore throat, and also depression and anxiety. And what I hope is obvious from that list is that it's incredibly broad. There's a huge variety of symptoms, 60 as I said, that are associated with long COVID. And to date, there's been none. I suppose there's been no consensus on what are defined symptoms that must be experienced for it to be long COVID. And also many of these symptoms, such as fatigue, for example, may be prevalent within the general public anyway. So it is quite difficult in how we define long COVID previously in terms of what timeframes we use, but also in terms of what symptoms we specifically use to define it. Then kind of moving into prevalence rates and prevalence of long COVID. Meta-analyses exploring long COVID have varied, unfortunately. And specifically one meta-analysis conducted by Woodrow et al. Found that studies that report long COVID and diagnose long COVID by self-reported symptoms predict significantly higher prevalences compared to studies that diagnose COVID using healthcare records. My memory of that study was that I think it was around 30–40% prevalence if diagnosing long COVID by self-reported symptoms, whereas it was roughly around 10–15% prevalence if diagnosing long COVID using healthcare records. So clearly a big discrepancy in terms of kind of the validity of prevalence rates, prevalence if we use self-reported or healthcare records to define long COVID. And then using data from the Office of National Statistics here in the UK to kind of supplement the research. And we could see that approximately 2 million people in the UK were experiencing self-reported post-COVID-19 syndrome in the first 2 months of 2023. Unfortunately, the ONS has not continued this particular these reports from the COVID-19 infection survey past the first 2 months of 2023, so it's impossible to know exactly how many people are currently suffering with or experiencing PCS at the minute. But this figure from the first 2 months of 2023 equates to roughly around 3% of the total population in the UK, and also around 9% of all PCR confirmed cases at the time. So from this slide, we can roughly estimate that around 10% or 1 in 10 people who experience COVID-19 will go on to experience symptoms for 3 months or more. As well, roughly around 3% of the population of the UK, we can see that this is an important disease that experienced by, or condition, should I say, that is experienced by a lot of people. And also, while we don't know the risk factors, kind of research around general, or we don't know the cause, research around risk factors conducted by studies that looked at the general public found that there are certain risk factors. And the results of meta-analyses conducted by Sampasian et al. Of 41 studies found that conducting kind of statistical tests across the different studies, that there are certain risk factors that are significant and should be explored for developing long COVID. And these include being of female sex, being older age, and also having a higher BMI, which were all associated with greater odds of reporting long COVID. Risk factors also included health factors, such as having a pre-existing medical condition prior to becoming infected with COVID-19, and particularly having a respiratory illness such as asthma or COPD. Also having fewer than 2 doses of a COVID-19 vaccine was associated with greater odds of developing long COVID, and also being hospitalized during the acute COVID-19 infection, or in general having a more severe infection. during that first 2 weeks of the infection was associated with greater odds. Also, there's been kind of a growing smaller body that has explored and has found that poor mental health prior to COVID-19 infection is a risk factor for reporting prolonged symptoms. But this has been, I suppose, less investigated in comparison to the other risk factors on this slide. And then to move for the broader general public more into healthcare workers, we know that the COVID-19 pandemic has had some unique kind of impacts on healthcare workers that we're working throughout. And research again from the UK and from the Office of National Statistics has found that healthcare workers were among the occupational groups at highest risk to becoming infected by COVID-19 during the first year of the pandemic. And thankfully, this effect diminished after the first year, likely due to increased access to PPE and also greater knowledge around transmission. And also, ONS data has found that healthcare workers were at significantly higher risk in comparison to most of their occupational groups of prolonged COVID-19 symptoms, and also at higher risk to death due to COVID-19 during that first year of the pandemic. And again, thankfully, that has dropped over and after that first year. But due to their exposure to COVID-19 and increased risk of, first of all, catching COVID-19, then also experiencing prolonged symptoms, and also, having a more serious impacts due to the COVID-19 infection, it is likely, at least in the UK, that healthcare workers are at high risk to long COVID, especially given statistics that 1 in 10 will go on to experience prolonged symptoms for 12 weeks or more, and especially given the risk factors that we know are associated with long COVID. So to kind of explore this in more detail, we conducted a review of studies that looked at long COVID among samples of healthcare workers. And just to give kind of a broad overview of the literature review, we conducted a narrative literature review, was the exact type of review that we conducted. And we explored published English language original research articles looking at long COVID among samples of healthcare workers. We searched for citations to be included in the review in 5 electronic databases. And we also reviewed 4,121 unique citations that were identified in each of these electronic databases. And the end of the, I suppose, review period, we included 31 articles within the first version of the literature review. And these studies report on a total sample of 14,681 healthcare workers working in a total of 16 different countries. And as a note on the 31 articles that were included, most were quantitative, so 28 of them were quantitative. There was 2 qualitative articles and then 1 mixed methods study. And then also most of them were cross-sectional. So 24 studies were cross-sectional, meaning that they only collected data at 1 time point, whereas the remaining 7 were longitudinal, collected data at multiple time points and followed healthcare workers across a period of time. And while we present the results of the narrative literature review that we conducted, we also note that there's an ongoing meta-analysis by the UK REACH team, who are based in Leicester. And this will be using statistical tests to, I suppose, explore the prevalence of the risk factors of long COVID among healthcare workers in a little bit more detail in comparison to the narrative literature review that I'll present today. The reference that I've cited by Amani Al-Arabi is the protocol for that systematic review and meta-analysis. It's available on the BMJ if anybody would like to access it. And first, to kind of consider the prevalence and the symptoms of long COVID. So the prevalence of post-COVID-19 syndrome, PCS, or that NICE definition for symptoms for 12 or more weeks, varied from a low of 12.8% to a high of 75.4% in the samples that were included within the review. So huge variation in terms of how many people went on or became infected with COVID-19 and then went on to experience prolonged symptoms. And really, key point of this is that there's huge variation and huge variation in quality, especially in sampling in these studies. Some of the studies had a huge bias in terms of how they picked their sample and who they included, and really points to kind of low quality in a lot of the research as to how they measure prevalence and how they objectively get figures to identify how many people had COVID or long COVID. Then also in terms of the symptoms that were used, the most common symptoms were fatigue, which was studied in 24 of the included articles. Memory loss, difficulty concentrating, was the second most common symptom, and that was measured in 12 studies. Shortness of breath was the third most common symptom, and that was measured in 20 studies. Loss or decrease of sense of smell and or taste was the fourth most common, and that was measured in 16 studies. And then also joint aches and pains was the fifth most common, and that was measured in 12 studies. So what's important here is that even though these were the five most common symptoms associated with long COVID across the studies, none of them were examined in every single study. We have huge variation in terms of which studies measure which symptoms, and this makes it very challenging. How do we directly compare prevalence rates or compare, findings around post-COVID syndrome if we're using different symptoms to define the condition and to measure the condition. So certainly more work needed to standardize and kind of figure out what are the most important symptoms associated with the condition, and how can we be as consistent as possible in reporting the symptoms across studies. Then in terms of risk factors, evidence on the risk factors for long COVID in our narrative review is inconclusive. And the big note here is many of the risk factors were found to be significant in certain studies. However, none were consistent across all of the studies. So for example, risk factors that fit this bill included being of older age, and this was a significant risk factor associated with higher odds of having long COVID in 8 of the 19 studies in which it was examined. Being female sex was significant in 5 of the 18 studies that it was examined in. And also having pre-existing illness was significant only in 4 of the 10 studies that it was examined in. So huge variation in terms of whether or not risk factors are significant across the board, and that is a challenge also in terms of pooling the results and getting sort of objective comparisons between the studies. And interestingly, despite that kind of emerging evidence that it is an important risk factor, none of the studies included in our review explored if poor mental health prior to COVID-19 infection was a risk factor for COVID-19 or for long COVID even. And it's important to take the evidence base to base, see what factors become important, and then to build models around, always keeping in mind if certain factors appear important that they should be included within the research to give the most objective and full picture as possible. Additionally, as a note on the studies that were included in the review and also examined risk factors, most of these studies explored risk factors were cross-sectional, again, meaning that they only collected data at one time point. For risk factor analysis, it would be ideal to collect all of the data for the risk factors prior to becoming infected with any of the whatever illness you're studying. But for most of the studies included, all of the risk factors were collected at the same time that most people had already experienced long COVID for a number of months. So certainly some bias estimate within those calculations. Then some of the studies also explored impacts of long COVID. And the first of these studies that I've pulled out for this example is that the majority of healthcare workers who were experiencing post-COVID-19 syndrome in a study from the UK, so 69% of healthcare workers, agreed with a statement that they were struggling to cope with their symptoms, specifically in terms of maintaining a normal everyday life, in terms of maintaining their personal responsibilities, but also going to work. They said that they were struggling to cope with their new symptoms and how those symptoms affected their ability to undertake everyday activities. In a second study, healthcare workers with PCS in a German study reported lower physical and mental health compared to their colleagues who also reported COVID-19 but did not experience prolonged symptoms. So another clear impact of lowered physical and mental health in comparison to colleagues that did not have to deal with, I suppose, the challenges presented by symptoms or prolonged symptoms. And also in a professional sense, Research from Germany, Italy, and Switzerland has found that healthcare workers with long COVID report reduced workability and also increased functional impairment compared to colleagues who also had COVID-19 but did not experience prolonged symptoms. So just some impacts of COVID-19 and some, I suppose, quantitative evidence of the impact that prolonged symptoms could have. In addition, the literature review also highlighted some qualitative study that offered kind of a more insight and more in-depth view into healthcare workers' experiences of living and working with long COVID. And this included 2 studies that were conducted with clinical healthcare workers in the UK. As a caveat to these results, both studies were conducted within the first year of the pandemic. So they're true to that time, but obviously, 4 years on and 4 years since long COVID was first described, some of the results may be a little bit out of date, but it's still important to reflect on nonetheless. But obviously, first, healthcare workers in both of these studies said that they used their own medical knowledge to diagnose their symptoms, fearing that they were signs of more serious illnesses, such as pulmonary embolism or myocarditis, were the examples given. Particularly, healthcare workers said that they used their own medical knowledge in absence of any sort of broad knowledge at the time. And this kind of feeds into the next point, in that healthcare workers also use the professional networks to get advice and reassurance from their colleagues in the absence of those official guidelines or care pathways published by the NHS. Additionally, healthcare workers said that they felt let down particularly in that first year of the pandemic, given the lack of support that they experienced when trying to access healthcare services for their long COVID. And they also called for dedicated long COVID healthcare services that provide tailored support for people living with the condition. And obviously, great example of in the years since, these long COVID, dedicated long COVID healthcare services have become more popular. And we would hope, much more easier to access than people initially had issues dealing with trying to access care. And these have really been able to overcome the fragmented care that these early people experience trying to access support. And additionally, many also said that their symptoms meant that they were unable to return to work, and many also said that they felt sharp disapproval from their colleagues and from their managers for taking time off. And particularly many said that they felt that their managers and their colleagues felt that they were making up symptoms just to take time off, when in reality, they were often unable to do anything other than lie in bed, especially at the peak of their difficulties with their prolonged symptoms. So yeah, a lot of stigma around long COVID and feelings of disapproval that some people have experienced. But that kind of is a broad overview of the literature review. Some kind of key points to note, which I hope have been clear enough in the presentation. But the first is that there's clear evidence that those affected by long COVID may experience significant personal and professional challenges due to the prolonged symptoms. This, we would hope, is not in debate. Long COVID is prevalent. With 1 in 10, there are certain risk factors associated that put people at greater risk than others. And also, the experience of these prolonged symptoms may have a significant impact. That is not a question, and the research has been very clear in communicating that. However, in terms of challenges and further work required for the field, there's a huge disparity in how long COVID is defined within the literature. So first of all, as I said, there's a broad variety of symptoms that have been used to diagnose the condition, and also there's different time frames used to diagnose the condition. And these, it would be ideal if we could converge on a specific set of symptoms or on a universal time frame that could be used. It would make comparisons much more standardized, much more objective, and would also help, in our understanding and build up our understanding of the condition. The second issue is obviously the lack of a scientific consensus around the mechanism, or some people believe it's more likely the mechanisms that cause long COVID, and specifically trying to identify and being able to identify what the biological mechanism that causes long COVID would help in developing treatments for the condition. Obviously, if we don't know what causes the condition, it can be quite hard to figure out exactly how to help people living with it or how to remedy that problem. But in the kind of time since long COVID has been described, there's been a growing body of kind of research around treatments for the condition, and obviously we hope that those continue and continue to show some positive results. And then finally, there's also a lack of high quality longitudinal data that explores healthcare workers' experiences with long COVID. As I previously said, while it would be preferable to have longitudinal data when exploring risk factors, access to longitudinal data would also help us follow up healthcare workers to know after a year how many people have recovered, how many people are still responding or reporting those long COVID symptoms, and help us kind of figure out what's the prognosis for the condition, which can still, at this point, be quite unsure. So certainly much more work to do within long COVID, but certainly more interesting findings available. And that is my presentation. Thank you all for coming along and listening, and again, thank you to the Code Foundation who supported the work.
Excellent. Thank you very much for that, Brendan. Can I just remind people to put themselves on mute, please, because we've got a little bit of background noise coming through. Okay. Any questions from people in the group? We've got some hands up. Anne Ward. Hi, Anne.
Hi, Brendan from Dublin.
Hello.
I don't know if I'm allowed 2 questions, but so the first one is, I'm a psychiatrist, whether there's any way to help us discriminate presentations of chronic fatigue and fibromyalgia, which we see a lot of in people, some of whom have had COVID from post-COVID.
Yeah, I suppose my first point might be a caveat to that. I'm not a clinician. I'm a psychological researcher, so some medical questions I probably won't have the skills or ability to answer. Again, I wouldn't be able to advise on how to discriminate in clinical practice between people with long COVID or other conditions. I don't know if anybody else in the...
Yeah, Brendan, I was going to suggest we've got some clinicians in the group.
Yeah.
In this session, just wondering if one of our clinical colleagues might be able to address that point that Anne was raising. Just while we're waiting for someone, so I've got some hand up. Era.
Yes, sorry. Thanks, Anne. And I can try and answer that. It's difficult is the answer. So it's really the history of the COVID infection and the symptoms developing following that infection that distinguishes from chronic fatigue syndrome. But there's a huge overlap between symptoms in chronic fatigue syndrome, fibromyalgia, and long COVID, but it's history.
Thank you. That is actually really helpful. The other question is that there are specific strange syndromes that are emerging post-COVID. And for example, I have a friend who was diagnosed with atypical Guillain-Barré and hypothyroidism. And because she was attending a specialist clinic, it was picked up, and she was told that was a recognizable post-COVID presentation. And I'm just wondering how much is known about these more syndromic things where you can actually identify physical problems, like a very low thyroid, for example, thyroid level.
Again, we might see one of our clinical colleagues pick that question up. Back to Era.
Yeah, sorry, unless any of the other clinicians on the call know, I'm not aware of that association, but I seriously haven't kept up with there's a huge amount of literature out there, but somebody else might know. Yeah, Joe's got a hand up there.
Hi, I'm a respiratory doctor and not seeing many people, fortunately, with this, but just anecdotally, if somebody comes in with symptoms that might be following on from from COVID and they're reporting fatigue, we would ordinarily do a thyroid function test as part of the assessment. And anecdotally, we have picked up some people with low thyroid function, as have people who are running long COVID clinics. But I don't really know how common it is, and what the instance is amongst people with the syndrome.
Okay, thank you both very much.
Thank you. And we have a question here from Paul Cullinan in the chat box. Have there been or are there any high quality therapeutic trials in long COVID that you're aware of, Brendan?
Yeah, to date, I'm not. I'm actually just having a Google of it there. I'm not familiar. There is the locomotion study. Sorry, it's been a while since I've looked at it. Yeah, so there's the locomotion study is the ongoing. I can send in a link to it now, but it's the Long COVID Multidisciplinary Consortium for optimizing treatments and services across the NHS, and that has had some work in terms of. I think it's an ongoing project, but it's done some work in terms of looking at treatments available for the treatment of long COVID. Ira, do you?
Yeah, so that's Trish Greenhall's study, Paul, and it's a big NIHR funded study, and she's got looking at a lot of different interventions, and that's the only one in the UK that I'm aware of.
Alrighty, Brendan, thank you very much for a very thorough and comprehensive presentation describing some of the key points from the literature, if you like, with regard to long COVID presentation in healthcare workers.
Thank you.
We've got a question here from Kathleen Lynn, who's one of our consultants in occupational health at Guy's and St Thomas's. Is there any data on the duration of long COVID? For example, how many are still functionally impacted after 6 months, 1 year, etc.?
Yeah, so that's again kind of a huge issue within the review that I kind of did, is that a lot of the studies are cross-sectional and they don't follow people up over time. So the majority of the data is taken at 3 months or 6 months, and again, it's difficult to know what the exact prognosis is with cross-sectional data. We don't have the data to follow people up. I don't know, Ira, if you have.
No, I don't know any more than that. I think there's so just Brendan, there's another question to say,
Yeah.
just so that I'm not sure that I understand, that your review was done in 2021. You did it last year, didn't you?
Yeah, early 2023.
Yeah, that's what I thought. So yeah, sorry, I don't know the question that Kathleen's put. And again, if anybody else does, please pipe up. And also, Brendan, presumably you're going to present the results of the work that you've been doing on the longitudinal data at a separate session.
Yeah, we can. Yeah, later in the year, absolutely. Yeah, we can present findings from the NHS check work that we've done.
Yeah, great.
Sorry, Brendan, I've got another question from Kathleen. Also, any studies that tell us proportion of healthcare workers with long COVID off work and need adjustments?
Again, a lot of work needed in this field. It's one of the studies we have in the NHS check cohort. We're looking at sickness absence, but there hasn't been a lot of I suppose, larger studies looking at percentage of healthcare workers with long COVID. To memory, there was some news articles, but I don't know if they were informed by just reports given to them by occupation groups, or I'm not sure how that the figures were informed, but there were some news articles to memory a couple of months ago about thousands of healthcare workers still off work, but I can't speak to the validity of those claims or those figures.
Okay.
We have got that data, we just haven't analysed it. So
Okay.
Yeah.
I had a question, Brendan. You mentioned briefly about long COVID clinics that have been set up in the NHS to support healthcare workers.
Yeah.
Do you know what type of therapeutic support they're able to offer to healthcare workers? Did your review pick up any of this?
So the review didn't pick up anything from the UK, no. Again, my understanding is that the services are kind of based on a one-by-one. That people are, I suppose, given services based on their presentation. But again, I wouldn't be able to give further information on that, unfortunately.
Okay, no worries. And I thought I saw Joe Yarker had a hand up.
Hi, sorry, I came very late, so I missed most of your presentation, unfortunately, Brendan. But it's just to the point about data available for the long term. Sorry, how many people do remain impacted? There's only the stuff that I've come across has been the ONS data, but it's not healthcare specific. But I can post that in the chat. But also, I was wondering if there was anything from the TUC study. So they looked at self-report length of condition, and so there might be something in there.
Yeah, I'm not incredibly familiar with the TUC. Again, that'd be a great resource to look into a little bit more in depth. But yeah, I'm not familiar with those particular results from the TUC. But, yeah.
Okay, thank you. Thanks. And I've just got a final question from Sally. She's just querying if there are any links to the funding was made available for supporting long-term absence for long COVID. I'm not quite sure what that question's asking.
So my understanding, I don't know, Sally, are you talking about the special payment that was for NHS staff suffering with long COVID?
Yes, because I was working in the ambulance service at the time, and it made a big difference because people were able to be moved to much lesser duties. Some of them were on support vehicles and making tea and coffee for their colleagues, which they could just about manage when they couldn't do anything else. And then it disappeared again. And I just wondered if there was any sight of that. Because it allowed them to work on very, very restricted duties and feel purposeful, which we know is really important. I just wondered if it turned up in anything. Thanks, Brendan.
Yeah, unfortunately, no. I suppose research around that at the minute. We're trying to, I suppose, build up some research. Obviously, the payment was started to remove. I think was it the people returned to their normal contracts in September 2022, which gave them 6 months of up to 6 months of full-time pay, and then another 6 months of half-time pay. But there's been no research to my knowledge. Anne, do you?
Yeah, there was a BMJ publication before Christmas looking at increasing suicidal ideation in healthcare workers during the pandemic. And as far as I remember, there wasn't any attempt to link that to illness. I think that would be a very important thing to do because of the disbelief that people have written about meeting, in their colleagues, that they're in addition to the symptoms, they're faced with, oh, for God's sake, pull yourself together kind of response, which can't help.
Of course, yeah. Ira?
Yeah, thanks, Sally. The Danny Lamb is leading a grant proposal, and one of the looking at some of the interventions that were put in place in during and post COVID and the effect on mental health and well-being and staff retention. And one of those is that long COVID payment and linking it with ESR to see what the impact was. So watch the space. But nothing about it coming back. I think that's it. I think it's gone.
All right. Well, thank you very much, everyone. Brendan, thank you once again.
Thank you
for your presentation. And we have Joe Feary from Imperial, who will be running next month's session looking at firefighters and respiratory health. That'll take place on the 6th of February. So look forward to seeing many, if not all of you next month. Thank you all.
Thank you.
Thank you.